guys hear me okay?
It should be on automatically if you turn the
switch. Okay. It's got a little green light. I'm thinking that's good.
Okay.
Okay, excellent. So I am the Tammy on this slide, actually. I feel like, thanks, Kirsten, so much for inviting us. We are nurses. We are thrilled to be here. We're happy that you recognize that it's good to have the nurses in when you're thinking about design thinking and that we are making, because we are the largest number of healthcare professionals that there are, and we are with the patients 24/7, right? Thanks also for putting us in this spot, because we know that people are going to listen to Dennis and stay, and so that was good. We knew you would come back here, but we don't have to follow him. So Kirsten was really great. I mean, we are really thrilled about that, actually. I have the Godfather music on my phone, but I avoided it. I was going to do it, but then I decided, no, I will not do it. So just to tell you, this is a picture of the space. I'm just going to... The reason two of us are speaking is because I really think that I wanted you to hear from Rachel, who is one of these Maker nurses. I'm kind of the conduit. I am also an associate professor at our School of Nursing. If you know anything about UTMB, how many of you do? Do I have any nurses in the audience, actually? Okay, good. All right, that's okay. And then do I have any UTMB graduates from the medical school? You know, it's a very old medical school, like I think somebody else had talked about, very old nursing school. And so we do graduate a lot of people. One of the other interesting things is the University of Texas Medical Branch, or UTMB as we are referred to. We're on Galveston Island. We have some very unique, interesting things about us. Historically, I've been there 25 years. I was a nursing student there. I worked in the emergency room there, and then I was recruited to psychiatry and behavioral health, did a lot of stuff there before I finished a PhD at the Graduate School of Biomedical Sciences. And so when I started there, it was an indigent care hospital. Some of you may remember that. We actually were the people in Texas. We even got people from Louisiana who had no money and no resources. And so part of that, I think, is why we've always had innovative nurses and doctors there, because we would get patients who were so complex, and we would get them from everywhere. And we didn't have a lot of money at that time, and so we would have to really come up with things. I don't know if anybody's ever seen that. There's a great TV show that I watched called The Nick. Did anybody watch The Nick? Yeah, you remember? So that made me think of, wow, that's what it felt like kind of for us back in the day. I also sit on an IRB, so I'm not going to condone that kind of experimenting that they did. But again, it was one of those atmospheres. It was really an interesting place to be at that point in time. I was involved in this because I think it's been about 5 years ago. My CNO, we have a very forward-thinking chief nurse officer. We're also lucky in that he's been at our institution for 30 years, and that's really good. I don't know if you know about that, but when you have a lot of turnover, like some of the institutions do, you don't always get to develop those relationships, you know, at the time. And so he is really supportive of us and really good at that. And he was at a leadership seminar, something on innovation 5 years ago, and he met Anna Young and Jose Gomez Marquez, and I think you guys are probably pretty familiar with them. They're the MIT, the Little Devices Lab people. And Anna had she did this great manuscript, and I think it's about to be published. I was lucky enough to be able to read it, where she started this Maker Nurse movement. And in the 1930s, I think it was like 1932, the early precursor, I think this is kind of like maybe the precursor of social media, but it was actually writing, right? So there were these posts. They called them the trading post. And so nurses, it was part of the American Nurses Association, and nurses would write problems to each other. Like, I'm having this problem with taking care of this patient. And it used to be a lot of community health nursing. You'd be out in the public, you'd be doing things. How do I solve this problem? And then write it. It would get posted somehow, and then somebody else would respond, I'm doing it this way. And so she has a lot of neat old documents that show that. And so nurses have made, I guess forever probably back in the Florence Nightingale days, and used to share it. So David called me when he met them and said, they're doing some multi-site research, and would you help them do it would you be one of the PIs for our site and help them with that? And so that's how I kind of got involved, and then eventually administratively have kind of taken over the space, and am lucky enough that I get to mentor a lot of graduate students. And so when Rachel talks to you, she's going to tell you that the Maker Space is kind of one of her projects, and she is a maker nurse. And so we'll talk about that. In the research, you can read the manuscript. The interesting thing that we did was just ask what kind of nurses make, what areas are they in across like 5 sites, why do they make, and some of the drivers of making are just like you might think, kind of like I alluded to with UTMB. Some of the drivers that they answered were a need to solve a problem. One of the last speakers, I think you were talking, you were great about showing how many times nurses have to walk and do all that stuff. So one of the other studies I was involved with Dr. Kat Stevens at UT San Antonio was across about 26 hospitals. And so in addition to nurses walking that much, I think Anita Tucker was one of the engineers that worked with us on that. And so the other interesting thing was that they encounter what's called frontline operational failures. We just published a manuscript on that, and it was one of the first studies in the med-surg unit. So not only are they walking all those times, but they're encountering, across the 26 sites, they're encountering an operational failure 1.2 times an hour on a 12-hour shift. So that's an additional walking, trying to figure something out. Somebody mentioned, I think last night, nurses kind of wonky solving problems or something, right? And so one of the interesting things is I think they're solving them because they need to just in time do something so that they can take care of the patient, go back, get all the things. Just like physicians, I think we all have those kind of things, but they're stepping even more than you may think. And then they're on the phone. So they're stopping, What we didn't do is a time study on how much time each of those operational failures is costing them. We have great qualitative data on that across all those sites that we haven't even analyzed yet. So you can imagine what that's going to look like. There'll be a lot more things that we need to solve and look at. So that is how we got started. I did the research with them. Then they started coming and kind of looking at our nurses. We had a couple of nurses who had already been recognized for making some things. So one of the other unique things about UTMB is we have the only prison hospital in Texas. So all of the prisoners come to us. All of the pregnant women actually come and deliver their babies if they're in the prison system here. So we have that as well, which is unique. And so we had a prison nurse who had designed something interesting to help her get in. That's a unique environment where they have to get in and out all the time. You have to have a guard with you. There's a lot of barriers to actually timely care with patients. And so she designed something to help with that. And then we had a cath lab nurse who, I don't know if you guys are familiar with the cath lab, but in ours, how we would prop up patients' arms sometimes was just piling them up on towels and then wrapping them with tape. So it's kind of an old-fashioned way. And all of these stories are on. We have a YouTube, UTMB Maker, and you can go and look at some of these stories on that Makerspace. You just Google UTMB Makerspace, and you'll see all of the kind of things that we have done, and these nurses' stories in very short snippets, which are fun to watch. But one of the things she did is she had gotten an arm board. She designed an arm board. She didn't even know anything about. She said she went to Home Depot and learned how to saw and got some material and had done this. Funny thing about nurses, and this came out in the research study across sites as well that we did, is that they don't really want to draw a lot of attention to themselves. As a rule, there's outliers, right? But as a rule, they don't like to. And so one of the things that was interesting is when I first met Anna and Jose, they said, we want to talk to these nurses. We're going to bring them to Robert Wood Johnson Foundation. And they were like, most everybody would say, oh, cool, I get to go to Robert Wood Johnson Foundation. I'm like, oh. And so the funny thing was we sent my ER nurse there who had done she's in the ER now, she was the cath lab nurse, and she had called me from there and said, okay, what do I have to do here? So she didn't really, the recognition is something that they don't clamor for all the time, but they do enjoy doing things. So that was really fun in that regard. And so I think we've had, due to being the Indigent Care Hospital and due to having these unique circumstances, we've been lucky to have nurses that are creative and like to solve things. But they're probably everywhere. We just haven't, we just want to keep finding them. So they're probably everywhere making. And when we partnered finally with Anna and Jose to have somebody, we actually did get a maker space in the hospital. We started with a little cart, then it went into having an actual space. Then we got an engineer. Right. He was kind of an engineer / architect. He had a very nice broad background. And I remember whenever Anna and Jose and I were talking, one of the things we said is we really need somebody, if somebody's going to work with nurses, and then also it morphed into working with physicians and having some interdisciplinary prototyping and planning and ideas, we needed that person to be someone that wouldn't be intimidating to non-technical people and would have some pretty good people skills. And so that was one of the things that they said, okay, we really want to make sure that our parlance is kind of emotionally, socially intelligent and able to do that. And they have been fantastic in helping us identify, and we work together to do that. And we have another consultant now who is about to start, who is fabulous at that. And Andrew, who was the one before, who had this engineering background and design background, was excellent. Everybody loved him. He didn't intimidate the nurses. He came in with an idea. I even would take him around with me on rounds intermittently, and we'd go to SICU, we'd go to all of our trauma centers, we'd go to the prison hospital so that he could know, because he would help us think about how to solve problems, but he didn't know what a stopcock was, right? He didn't know what an A-line was, so some of those things were that he would see them and look at them. So I'm going to turn it over to Rachel now. That's really how we got the space in the hospital. We have it now. It's used. It's morphed, and I think it will continue to morph. But I'm going to let Rachel, as a Maker nurse, tell you more about what we've done and what we'll do. So thank you.
Thank you, Tammy. So hi, I'm Rachel. I'm a nurse at UTMB, and so I just want to talk to how we got, Tammy already told you how we got a Maker Space, and what is a Maker Space. It's a part of the Maker community, and this is where we can DIY solutions. And I think we had a good example of this with Dana earlier, in that the products that we need are coming too late, right? She needed a product 6 years ago. And I actually was at another conference with Tammy just a couple weeks ago, the Nursing Science at the Bedside Conference with the Texas Medical Center Nurse Scientist Collaborative. And Kelly Brazel from MD Anderson gave a wonderful speech in saying that our patients can't afford to wait, right? So they cannot afford to wait. The innovations need to come now. So in putting a maker space where we have a space with all these tools that you can see, these are just, a few tools, but we have a 3D printer, a sewing machine, a laser cutter, woodworking items, anything you can think of. It allows us to have those products in the hospital, so that way we can actively do this on site instead of having the nurse from the cath lab having to go to Home Depot, then go find somebody with some tools, and then spending all of that extra time trying to gain all these resources. And plus we have consultants who can help teach us as well. So I want to say that as a maker nurse, when I went into the maker space, guess how much knowledge I had to use any tool besides a screwdriver? None. Actively, my parents, I like to share this story as a maker nurse, that I walked in there with no working knowledge of tinkering besides doing very minuscule tasks, because my parents actively said, you don't need to do that. You're going to go into the medical field, ever since I was a little kid. So I was kind of led into that path. And so now this is kind of a way for me to also rebel in a good way. So, hooray. So now that we have the maker space and we're part of the maker community, we actually had the first maker space in a hospital, and this was an article in PopSci that when Jose and Anna came and they helped establish this, as Tammy said, it gave us the tools that we needed to start creating. And so there's a lot of things that we all have ideas about as bedside nurses, and all nurses have, because we run into things on a daily basis. And I want to say that there was a study, correct me if I'm wrong, Anna, there was like workarounds as a nurse. So workaround is using something that is not what it's intended for, right? So there was like 6 to 9 workarounds an hour on a 12-hour shift. It was quite a bit what nurses are doing at the bedside. So having the maker space can actually make some of these workarounds not only intentional, but we can also encourage the safe use of workarounds, because workarounds in nursing world is like a negative term, because sometimes they lead to unsafe things that we don't want to happen. But when we do have a need for a workaround, that's saying that there's something wrong with the system, right? And maybe it's not serving a purpose like we need it to, or we need something else. So putting a makerspace, what does a makerspace do for us? This is some data that Anna and Jose from the MIT Little Devices Lab collected. And on the left is the 4 different hospitals with innovation programs that participated in gathering this data. So they had almost 70%, 69% of their creations were coming from MDs and PhDs. When we opened up the makerspace and started rounding, we found that other people that had ideas, it wasn't just nurses, it was people across the spectrum of the health system had ideas. We had 25% that were nurse clinicians. Our police department, the UTMB police department, even came and started utilizing the 3D printer, which also produced a return on investment for them, right? So they were able to produce some simulation gadgets that they needed that would have cost hundreds of dollars, but they made it for just like 10. So that was nice. So back to nurses, we are inherently, and this is something Tammy discussed, we're inherently makers. So what you find in the text is that we're finding texts from back in the 1900s that were produced on how to do things to help care for patients back from 1917, 1947, and then there was the American Journal of Nursing series that Tammy was talking about, ideas that work. And so that was nurses having problems, and then they'd write in, and then people would answer them. And how do we care for people? And a lot of this stemmed from community health nursing, because that's what was being done back in the early 1900s, was a lot of community health nursing versus inpatient. And now we've shifted from less community health now to more inpatient, which is a part of the whole health structure that we were talking about earlier. So the nursing process, how does I've heard a lot of design thinking, so I haven't been introduced to that, and so it's been very, educational for me coming here. And so when I'm hearing design, right, I think of the nursing process, because nurses are taught to critically think in a similar way, and that we assess the problem, so we're listening, gathering data, what's going on. We diagnose, so what is the problem? We develop a plan, we implement, and then we evaluate. And it is that big circle, just like that we have design thinking. So it's very similar in that nursing are taught to critically think in a similar fashion. So I think it really lends itself to that. So this is an example. I was an ICU nurse before I was a nurse administrator. That's what my full-time job is now. I'm a clinical operations administrator. Basically, that is, I help get patients through the system, the inpatient system of the hospital, and help with the flow. So when I did bedside nursing, I worked in the surgical ICU, and I particularly liked taking care of cardiothoracic patients. So this is an example of what would be in an ECMO patient, which is extracorporeal membrane oxygenation, what would be in their rooms. So you have your computer to the right, you have your ECMO machine that's in the middle right there. In the back, I know the picture didn't really turn out well on the screen. You have a monitor in the back right-hand side. You have some booms that are going over the patient, which is in the middle. And then in the back there, you have a whole bunch of IV pumps and stuff. So what do you think is going to happen whenever you have a patient with all this? Do you see a lot of things that could be improved in this picture? Yeah. So there's probably a ton of things that we could do to help take care of this patient better and keep it very organized. And the joke is, I know Tammy has a behavioral health background, and the joke is that ICU nurses are OCD. And it's for a good reason, because there's a lot going on there, and you want to keep every line perfect to make sure that we have good outcomes for our patients. So coming from that background is what helped make me a maker nurse. So these are just going to be some examples real quick. I know I'm running out of time. But this is Colleen James. She's an ACE unit is basically a geriatric unit. And so we had patients that could not speak and were aphasic, but they could still, they still had those thoughts. They needed to get it out. How do I ask for basic needs? So she created a communication board on the laser cutter with plastic, and this is now hanging in our geriatric rooms, and they could point to what they need. I need my walker, I need my cane, I want to eat, I need to go bathroom number 1, I need to go to bathroom number 2, so that way we can help get those basic care needs. And the good thing is, going to infectious disease, these can be cleaned off with Cavicide, and it could stay in the room. So it's also purposeful. It's not just a one-time use. We can continue using these items, and it's to help provide a better patient experience. So this is something that I made, and I actually brought it. When we built, so this is a good example of what we were talking about, designing new hospitals. So when we built this new hospital, and we bought a new recliner chair, right, for to go in every room, and they did not have Foley hooks on the chairs, whereas we used to. And one of the big things about being in the hospital when you're sick is getting up out of bed. Ambulation decreases the risk for pneumonia, infection, all sorts of stuff. It's just not good. You have to get out of the bed. So even the sickest of the sick, even that ECMO patient that you saw, we will want to get them out of bed once it's, safe to do so, even hooked up to that big circuit. So when you have patients like that, you need stuff to hang places. You can't just get them out of bed and then just go, oh, we're going to put this on the floor. No. So we were actually, if I was the chair and this was the bed, we were hooking the Foleys on the bed and then just kind of inching the chair over to it. And then you'd have the IV pole right here, right? And so then the nurse is trying to reach over the Foley, like slack of the line to get to fix the pump. And, there's always risk for tripping or dislodgement. So one day, the other problem is with nursing is that we don't have enough time to do anything. But one day I did have time. It was amazing. So I went to the Maker Lab, and Andrew was there, and he helped guide me on how to make a Foley hook. And now I made 64 so far. But I only have 120 more to go. And then the whole hospital will be fixed. But it has been implemented, and it's great.
We mentioned that we're poor, right?
Right.
In the hospital.
Yeah.
So we're manufacturing.
We're manufacturing, but it's something that's simple. So once we got that going, these are examples that are improving patient care and safety. And then how we're showcasing, we are a part of the Maker community, and so we've been visiting Maker fairs around the country. So there is, I think, Maker Fair 2015 or 16 was in the middle, and up top is 2017, and then on the bottom is Maker Fair Houston 2017 as well. So we've been trying to spread the word and be an active involvement in the Maker healthcare community, because they do have showcasing sections that we can help educate. And some of these ideas can help be implemented in the community, like the Foley hook. People that were outpatient, that were in wheelchairs, were like, man, that is exactly what I need on my wheelchair. So it's not just for inpatient. You could use some ideas that you see on the inpatient side and spread those for people that have chronic health conditions. So the Maker Health community for nursing is, I think, a really good way, because we're there at the bedside a lot. So I appreciate your time. I know we're out of time, but now it's time for Q&A.
Let's give them a round of applause. We have time for just a few questions. I'm going to hand out some microphones if we need to.
Questions?
Okay, while the audience is thinking of a question, I have a question for
Okay.
you. Can you tell me what is the right size problem that can be solved with your makerspace?
The right size.
The right size.
Yeah, not too big, not too small.
So I want to say, first off, we've been hitting a lot of problems lately that is low-hanging fruit, right? So some of these examples are low-hanging fruit, but we have had some bigger problems that Jason Schaefer from our burn unit, and burn patients, we have to tub them and clean them on a table, and it's very labor intensive, right? And so he had created a tub system where the nurse wasn't having to hold the nozzle to spray off. They would have a tub system that could clean, that went over the patient's tub bed. So that's a big problem. Now, we haven't gotten to the systems problems yet, but I think as we grow, we're going to see more of that.
So thank you. I have never heard of this before. I am absolutely fascinated. Question, is there a vetting process for these innovative
Oh, for like implementation
problems?
and then...
Yes.
So when a nurse comes up with an idea, we have them come in and take the ideation and immediately try to get them to create the idea and get the prototype going. Before we implement, we automatically have them go through the IRB, so that way we can make sure that what we're doing is safe for not only the patient, but for the providers as well, because we do not want things that could be implemented are not just a risk to the patients, right? And we got to make sure that it's safe for both sides. So we send things through the IRB.
But we don't discourage any ideas at all.
Right.
There's nothing that would be considered a dumb question.
Right.
What we really say is if you think, we've been trying to really change the culture. So one of the cultures, we've been collaborating a little bit with Texas Children's Hospital. They call us a lot.
Right.
There's some advanced practice nurses there who have created things that we've talked to. They have a great photo of a little kid, talk about kind of ridiculous, of this little kid trying to walk down the hallway with this IV pole full of like stacks of monitors, right? And so it's the absurdity of that where we go, can we make that something better? And so I have helped him kind of think about how to do a pilot study on that small, probably an FDA-exempt device, but we would look at that and see.
Right.
But yeah, I think that it's amazing, but we don't want anyone discouraged. So we want them to read something, look at that, think of it. I get systematic reviews all the time, and some of the times I just got one the other day, neonatal intensive care unit nurse, I send it to them, they'll call me and say, well, how can we make this better? It would be about cognitive intellectual delays in very low birth weight babies being born. What does it look like causing that? One of the big correlations was overventilation, or the fact that we have to mechanically ventilate for so long. And so they'll say, is there something we could do to not have to do that? And so then we'll kind of brainstorm and sort of think about those things. Other people are thinking about them sometimes, and sometimes they're not feasible. But we don't like to discourage that because we want the thinking to happen. We want them to think about that, think about how they can make things.
Can I have to follow up? Because I sit on an IRB.
Oh, okay.
So
Yeah.
is the IRB review for FDA exemption purposes? Because you're not doing research.
It depends.
Right.
We go through anyway, yeah. We will go through anyway, and I know since you said I sit on an IRB too, and even IRB members will debate whether this is FDA exempt or not, right? And so sometimes it becomes very interesting, and we always have legal, like you probably always have legal there. And so sometimes it's that, sometimes it's just that we want to check with them. And sometimes, like she said, it's about feasibility. So we really are thinking about the patient. We're thinking about how this is going to impact the patient, it's going to touch the patient, it's going to be okay for the patient, but also the nurse. So like with the burns thing, we started watching the nurse and noticing the nurse. So we would go and look, and we noticed that this could have been a repetitive injury, the way he was doing this. And so we were like, and I'm not even an engineer, but we started thinking about that. And so we want to test that as well. Right, so not are we only measuring how it's impacting the patient, but it's also how it's measuring how it is impacting the nurse, and then how feasible is it in terms of that. So, yeah, it's a lot to think about, but we don't intimidate that. That's where I come in, and my science department comes in, so they're not bogged down with, oh my God, the IRB, I can't do that. You know what I mean? I'm not even going there. And so we come in and say, don't worry about it. We're gonna help you with that part.
So we have time for just one question.
So again, thank you so much. And I'm fascinated. Sometimes in the industry, I feel that healthcare is an industry where you're drinking from a fire hose with a sieve.
Yes.
Right? So there's so much happening, but it's all going off somewhere. So I'd be curious, like when you found something like the Foley, for example, are you communicating that to the industry? Are you sending it out to furniture manufacturers? Or because you've kind of found a solution, and it would be so criminally wasteful that there's somebody else somewhere else who's solving the same problem and spending the same amount of resources. They could be solving something else.
Right.
So I'd love to know how you're kind of sharing and going back to the industry with some of the solutions.
Right.
the most creative hacks that you've found because it wasn't designed right in the first place, right?
Right. So actually, those Foleys, there are chairs with Foley hooks. They just didn't purchase the one with the Foley hook. So that is actually there.
Right?
Yeah.
And that's what happened is they went ahead and they have a lot of executive level people making those decisions, which is fine. That's not always bad. But our mantra has always been, think about including the bedside nurse,
Right.
And the person that's doing it.
So in this case, yes, it was already there. We just didn't buy the right product.
But just in
right.
things that you're doing would be so great to
Oh, yes.
communicate it so that.
And we do communicate through the Maker platforms, and we do have the YouTube. And I know that we're working on dissemination and getting more of this out there on more professional levels, on journals and whatnot. So, yeah.
That was okay because we work for a university and you know how that can go. So in terms of intellectual property. So
Let's give Tammy and Rachel another round of applause.